Hey, welcome back to Pathology. We're going to go straight on to part two, which are the nutritional diseases. A lot of this should be some review from the biochemistry. Okay, kwashiorkor. Remember, this is a protein malnutrition, but the child is going to be eating a lot of like carbohydrates. Without the protein, there's going to be peroxisomes to decrease the fatty acid oxidation and the bile acid. There's going to be an osmotic imbalance in the GI system thanks to the lack of like albumin. It's going to result in the diarrhea, the cough, shortness of breath, moon phases, hyperpigmentation, hepatomegaly, in particular apathy. So these kids aren't really going to be able to like respond to a lot of like things. Ascites is going to be your main clinical feature. So albumin is going to be very low, but renin is going to be high. There's going to be not a lot of glutathione, and this unfortunately has a very poor prognosis. So in this malnutrition, peroxisomes are going to be down. There's no fatty acid oxidation, no bile acid metabolism. So there's going to be hepatic steatosis, and there's going to be ATP deficit. So without the fatty acid oxidation, there's not going to be a TCA cycle. Oxidative phosphorylation is going to be down, and they will be apathetic and lethargic. Merasmus is just a deficiency of everything. It's the wasting syndrome. It's skeletal, no edema, bradycardia, hypotension, hypothermia, of course, because there's like nothing to keep the child warm. Anorexia. This one actually has a better prognosis. So they're going to be alert. They're going to be miserable though. Cachexia is basically marasmus, but it's seen more here in the Western country in the elderly, the cancer patients, and AIDS patients. The basal metabolic rate is going to be high, so the temperature is also going to be high. There's going to be anemia, low albumin and transferrin, and increased cytokines. So in cachexia, here we go with the tumor. The tumor's cells are going to be taking too much of the energy. So there's going to be the induced proteolysis, impaired regeneration due to the cells taking away all of the resources. So there's going to be wasting, inflammation, ECM remodeling, fibrosis. Then the heart, there's going to be atrophy and dysfunction. And the cells are going to be hypercoagulable. So there's going to be increased thrombosis risk. So it's going to affect everything. Malabsorption, bone metastasis, endocrine, exocrine dysfunction. Okay, so anorexia nervosa and bulimia, we're not going to cover too much of it because it's more of a personality disorder. It's body dysmorphia, but in a pathological context, it's going to result in amenorrhea. So this is like the main cause or the most common cause of secondary amenorrhea. Hypocalcemia, pretty self-explanatory because person's not eating. No vitamin D. Osteoporosis is going to occur thanks to the deficiency of these two. Mallory-Weiss tear and the erosion of enamel is going to be present in bulimia. So if it continues, the Mallory-Weiss tear can lead to intrathoracic bleeding, and that leads to mediastinitis. In anorexia, alkalosis is going to occur. Blood pH is going to be alkaline. Hypokalemia and arrhythmia is going to occur thanks to the hypokalemia. There's going to be an orange or yellowy skin thanks to beta carotenemia, and we're not really sure why that deposits in the skin. Vitamins, go back to Vodachem 7 and 23 for review. M3 promyelocytic leukemia is going to be a problem with the retinoic acid receptor alpha. and it's going to be caused by a translocation on the chromosome 15 to 17. So RARA is not going to be functional, and vitamin C can't enter the cell. So there's no maturation of all the cells. It's going to be megaloblastic anemia. Tumor lysis syndrome is pain due to the formation of uric acid as DNA is degraded, because DNA, of course, has a lot of like nitrogen. And colchicine is going to be used to treat that because colchicine inhibits the formation of uric acid. Okay, so back to problems with RARA. The M3 cells are going to be hypergranular. The cells are going to be red to purple cytoplasmic granules that are very large, and it hyperpigments the cells. There are going to be identifiable like matchsticks or faggot, like a piece of wood. Apparently, that's what it's called. They just look like rods, really. Cells with numerous hour rods. So hypogranular or microgranular APL is rare. It's going to be leukocytosis. There's going to be abnormal promyelocytes. Of course, they're going to be really large because they're promyelocytes. And there's going to be irregular nuclei and granulations that are sparser and finer than the hypergranular form. They are not going to have too many hour rods. As you can see here, AML3, look how big they are with a lot of granules. And here are the hour rods here. They're not as big, but they're still granulated. Okay, so vitamin D, made from cholesterol. You have to have fat and sunlight, normal kidneys, and normal liver to make the vitamin D. So in hyperphosphatemia, it's going to lead to hypocalcemia. So these two are kind of linked. And without vitamin D, there's going to be excessive calcitonin to try to like re-sequester the calcium into the bone. Of bile and lipases are also going to be made from vitamin D, and those need the normal GI to absorb vitamin D. Without it, it's going to patient's going to be either So without vitamin D, there's going to be presentation of either rickets in children or osteomalacia in adults. And then there is metastatic calcification from the vitamin D toxicity. So there's just going to be abnormal deposition of calcium. So in rickets, of course, there's going to be the bowing of the legs and all of the other problems. We covered a lot of that in biochem, so refer back to those lectures. Vitamin B, all of them have a role in making ATP. Any deficiency is going to lead to CNS abnormalities. B12 is the most important for myelin synthesis. And in pellagra, it's going to be a deficiency of B6. It's going to be dementia, diarrhea, dermatitis, and death. So in severe vitamin B12 deficiency, there is going to be like megaloblastic anemia, as you can see here. They're huge. There's going to be decreased platelets, decreased red blood cell survival, and decreased MCV if there is also a iron deficiency and some kind of thalassemia trait. This is pretty deadly. Folic acid is going to be also resulting in megaloblastic anemia. Cells need folic acid and B12 to mature. Before the anemia, the signs is hypersegmented neutrophil precursors. So there's going to be the delayed maturation, and they're going to be really big. B12 is going to lead to pernicious anemia because it has to be given not just like a B12 supplement. You have to give it along with folic acid and intrinsic factor. So intrinsic factor, you need intrinsic factor in order to absorb B12. Okay, obesity, a problem that plagues the developed country because it can lead to metabolic syndrome, and that is like heart disease, lipid problems, hypertension, type 2 diabetes, non-alcoholic fatty liver. This is actually like the number one cause of liver failure here in the developed world. In women, it can lead to polycystic ovarian syndrome. Of course, there's cancer, thanks to all the body's metabolism is increased. Too much oxidative stress is always going to lead to some kind of cancer. So, what cancer do we have to be worried about? In women, endometrial cancer. Thanks to the estrogen being stored in the adipose cells, so if you had a lot of adipose cells, there's going to be a lot of estrogen. Metabolic syndrome is going to have 3 out of the 5 components: elevated waist circumference, elevated triglycerides, low HDL, high blood pressure, and high blood sugar. That's it for now. Thank you for your attention and good luck studying.